I'd like to warmly welcome you all to this special Mobile Health Evening webinar. Speaker tonight is Ben Harris. Now, Ben registered as a medical laboratory scientist in 1978. Since then, he has had an extensive career in the diagnostic microbiology field. He's an honorary lecturer for the University of Otago and gives many presentations to multidisciplinary conferences, seminars and practices every year on microbially related topics, including our microbiome and its relationship to health and disease, emerging antibiotic resistances, and emerging infectious diseases. Ben's topic tonight will include the new reality, the Delta variant overview, how the RO numbers compare, vaccination progress, and there will be an extended Q&A session for you to ask those burning questions. Welcome, Ben.
Thank you very much, and I'm delighted to be here, and fantastic audience numbers, 361 I think at the moment, which is fantastic, and so I hope I have done due diligence enough for the presentation. I've asked if any questions, I may see some of them as they come up, please ask them, but when I don't, I've asked to be interrupted, and so that's not being rude. I've specifically asked to be interrupted, and also if I can be clearly told about 5 to 7 minutes from the end, and I can tie up any loose ends. So ask those questions, and I'm going to intend to do somewhat of a summary of COVID overall, but with an emphasis on Delta, which is the primary, virtually the only COVID-19 virus variant that's now being found in New Zealand and most of the world. It's the most successful variant, and so it's taken over the world, if that be the way of putting it. So we need to, if I can just get this going, there we are. Coronavirus deaths in the world, about 218 million and 4 million deaths. Coronavirus cases, I should say, 218 million, 4 million deaths. One could say, I have to point out, these figures are always very unreliable. You could say 2 million out of 100 million, which would be 2% mortality. But then we have to remember that many cases will not be, won't have been diagnosed. Many countries in the world have no PCR. So that 2% could go to 1% quite easily. And in other words, there might be twice as many cases because half of them are not found, and then half of all cases have no symptoms at all. So that 1% may drop to 0.5%. And in New Zealand, it's 3,500 cases, and with the 26 deaths. So at the beginning of the night, I wish to point out the key things for a start, and then because you'll be hopefully the most attentive at the beginning of the talk. So to start off by saying the wonderful messenger RNA COVID-19 Pfizer vaccine is not ideal, but it is a game changer. When I say it's not ideal, the ideal vaccine is something like measles vaccine, which it stops you catching infection and stops you spreading it and stops you getting the disease, measles disease, and it lasts a lifetime. So that's about 98, 99% effective if you've had 2 shots of measles. Whereas something like the whooping cough vaccine, that only reduces your chances of catching, somewhat like the Pfizer vaccine for Delta virus, it only reduces your chances of catching whooping cough, bordetella pertussis, by about half, 50 or 60%, but it does stop the whooping cough vaccine does stop almost every under 1-year-old who's vaccinated, almost guarantees they will not be one of the 1 to 2% that die of whooping cough, an awful slow strangulation over 2 or 3 days, effectively no oxygen. But for Delta virus, it's the most effective and safest vaccine and tool that we have. It largely prevents serious illness, so rather than all illness, may reduce your chances by about half of catching COVID-19, but it largely prevents serious illness involving hospitalization and hugely reduces deaths from COVID. So it takes COVID from being effectively a particularly lethal infection for a relatively small number of people to a mild infection, or much more mild infection for most without the lethality.
Ben, you've got a question.
Yes.
Can diet, lifestyle, and supplements affect the effectiveness of the vaccine?
That's a really good question to have early on. We have to remember Delta hasn't been about, it was described in May this year only, and COVID itself hasn't been going for a long time. There was a report in the BMJ, I read actually about 3 days ago, saying a straight, what's termed a vegetable diet or leguminous diet, seemed to, and this was a not a formal trial, but it was a observational study done by clinicians across many countries, and they were in high-risk jobs and for catching COVID, and they responded. So it's not ideal, but those that had a vegetable, what they termed a vegetable diet, probably reduced their chances of catching infection by about half, which is really interesting. Similarly, there's a trial and they published in the BMJ, but not peer-reviewed yet, in Ethiopia, and this comes into our microbiome. In Ethiopia, those that they just took the first several hundred people that were admitted with COVID infection, and those that had worms and helminths, or parasites and helminths in their gut, they had about a third less chance of getting serious infection. So that's all I'm going to say on diet. So a vegetable-based diet with fish, I should say, wasn't quite as good as the straight vegetable diet. And then this is for the clinicians. And then our vegetable with meat was higher serious infection rate still that the clinicians themselves call. Good question. Being fit and healthy, we know helps most things, but probably not COVID that much. We know that being ill doesn't help, but being fit and healthy, I wouldn't rely on it for stopping you getting infection at all. And I'll come on to that very shortly, but in some ways, the better your immune system, the more likely it's to respond, and that can include an allergic type response. So it may potentially be counterintuitively add some vulnerabilities to it. It's a good question, thank you. So the Delta variant compared to the earlier variants of COVID is, the last one is twice as infectious, and the jury is out on whether it causes more serious or severe cases or not. There are two relatively small studies that felt it did give more severe cases in unvaccinated people. It certainly causes far more cases, but they may or may not be more severe. There's some conjecture around that. But the vast majority of hospitalizations and deaths are in unvaccinated people. The vaccination has dropped the mortality and hospitalization rates hugely just by the vaccinated, even though there might be more cases themselves going on. Next one over. I've called it tracking COVID transmission. The COVID virus is about 0.1 of a micron, whatever that may mean. Bacteria is about 2 to 4 microns, and COVID, or viruses in general, about 0.1 of a micron in general, these ones are. So it's best to think of, if you were a smoker or sitting by a smoker, where that smoke goes is where the virus goes. So that's what airborne is. These tiny particles will go wherever the smoke goes. So an enclosed place or enclosed premises, whether it's at home or a business or, dare I say, a supermarket, is far more dangerous than in an open space. We know smoke, when we're smoking, just dissipates rapidly outside. So we look at the Crown Plaza, and to my mind, it beggars belief that this is perspex, but higher than head height, that smoke wouldn't drift over it. Absolutely beggars belief that they could have had isolated, high-risk people from overseas on one side of that perspex and the public walking through on the other. And in some ways, it's not even that, but it's the lack of knowledge that's allowed that to be signed off throughout the system. That's a worrying thing. And then you start including things like if there's air conditioning there, which way was the air blowing? Was it sucking the soap? Was it sucking the smoke over the top towards the public or the other way? There's always these things to be aware of. And here's the public walking through, and on the left you can see just the perspex. It beggars belief that can happen. The basics. I'm just going to go over the basics of COVID overall. There's an early, when we get it, and if we have symptoms, there's an early viral response phase, and that can be very, very mild, up to flu-like symptoms. And then we normally get over it as an influenza type time frame. But those people that end up being hospitalized or seriously ill and or dying then develop, they look as though they're getting better, then they develop an inflammatory second phase, which is your immune system suddenly getting into high gear and overreacting. It's like an allergic type reaction, and it goes absolutely bananas, which is why something like dexamethasone can work, because actually it dampens our immune system down and inflammatory responses, which is why I have some hesitation on thinking I'm fit and healthy, so I won't catch anything. I'm bulletproof. It may perhaps have some, there may be some counterintuitive things happen as well. Most clinical presentations are mild, as I said, and have, as it gets worse, maybe fever, cough, malaise, myalgia, headache, just like influenza. The earlier variants, those taste and smell loss was quite common, but that is much, much less with the Delta strain, much, much less. And so just to be aware of that. How are these questions coming along? Yes.
Do you want to go back to answer a few questions about the vaccine before you go further? Yes,
of course.
Okay,
yes.
So what is the majority consensus for having a booster dose of the vaccine, and is it being discussed having mixed variant of vaccines?
Okay, I'm going to start with the mixed variant. It looks as though, as in by different types of vaccine, I presume is what's meant. So different type, if you had a Pfizer for a start and a AstraZeneca later, it probably works. There's not very much written on it, but it probably works almost as well. The other one is, and it will, in case the intention was otherwise, the vaccine still works well against the Delta variant for serious illness, hospitalization, and mortality. It works very well against those. So, but we still, it may reduce our chances of catching it by about 50%, but we can still catch it and be asymptomatic, and we can still shed virus and spread it to others, even though we've been vaccinated, unfortunately. So it's more unlike the measles vaccine, it is more like the whooping cough vaccine. How long do the antibodies last? That's a big question. We know in nature that for all those infectious diseases that could be vaccinated against, there's never been a vaccine before now that's given protection for longer than that particular infectious disease has given protection for, so longer immunity than that infectious disease. So some things like measles last a lifetime, other things we need boosters after 5 or 10 years. We know in nature, humans and chimpanzees, I might add, can start recatching COVID after 5 to 8 months. And I have a cousin in London who is a first responder and has caught COVID twice, once in March last year and then again in October, I think it was last year, before the vaccine arrived. But, and now comes a slight trickiness, if that gap between the first vaccine and second vaccine is longer, perhaps 8 to 12 weeks, then we may get 4 times higher antibody.
Wow.
So the immunity may last longer. So there's all these subtleties. It may be that our immunity drops about 6% per month, but they get 4 times the vaccine height, that's going to last longer. At the moment, that's tricky because we want everyone in New Zealand to be vaccinated as soon as possible, but they're not going to get as higher antibodies if they just go for the 3 weeks or 6 weeks, they'll get more. But the sweet spot is probably at 8 to 12 weeks to get that absolute maximum. After one shot, you'll get around 50% protection.
Right. There's another question that several people have prioritised. What do you think about the person who is suspected to have died from a reaction to the vaccine?
From myocarditis, tragic. I'll come on to that later. I've got some slides on that later. And incidentally, if I don't get through all the slides tonight, they will be available online, so you can go back to them as a resource because I've got information on that. Lots of information, more probably than I'll be able to get through. Myocarditis from a vaccine may be about 1 per million people get myocarditis from the vaccine. This particular person, normally they're younger males that get it. This particular person was a woman, and I think she's middle-aged, but she did have several underlying illnesses as well, although the coroner thought that the vaccine was very much likely the main cause. Tragic, 1 in a million, but if you catch COVID, from memory, it's about an 18 times chance of getting myocarditis. So 18-fold higher if you catch COVID. Now in New Zealand at the moment, we're unlikely to catch COVID, but within 3 to 4 years, everybody on this earth, unless you're a complete hermit, will have caught COVID one way or the other. So we just have to bear those things in mind. So I hope that covers off.
A particular case study here, somebody wants your opinion on. Could you please comment? I saw a 12-year-old today with shingles post-vaccine, pain 1 day post-vaccine, classic rash 5 days post-vaccine, a fit and healthy 12-year-old. Is this actually related to the vaccine? And what should I recommend for their second vaccine, should they have it?
Well, they're not going to catch shingles twice, or I should say very unlikely to. So the second vaccine, second shot, as much as one can tell, is probably all right. We would have to look, once again, it must be notified that that's happened. And then you compare that to the normal population of people getting vaccines. Has anyone else noted around the world a slight increase compared to the normal population of shingles? In a 12-year-old, that's unusual. I suspect, and it is only a suspect, that the immunity goes down a wee bit as it's trying to fight off the infection, and that may have allowed the chickenpox to reactivate and cause the shingles. It's only pure conjecture on my part, but I suspect there may be a time, because it's pretty unusual for a 12-year-old to get shingles, unless they've got some other immune issues that you know of and or we're not aware of yet.
There's quite a number of questions, so I'll ask you again. Would you like to proceed with your presentation?
No, keep asking the question.
Okay.
Yes. Straight by the answer.
Do you have an opinion on ivermectin? Is that how you say it? Ivermectin?
Ivermectin. Once again, and that came in, I didn't mention before, on supplements. In general, I would steer clear of supplements until more is known. The standard thing is a randomized controlled trial is the best evidence, of course, and that can take quite a long time to do well. Ivermectin, the jury is still out. There's a really large trial being done. As far as I've seen at the moment, if it works, it's in a minor way, but I'm just going to turn it the same way. It could work, but I don't think it's going to be a game changer. I just bring in the other one at that side. I said about Ethiopia, those with parasites or worms or helminths, which is hookworm, if you like, they had a significantly reduced chance of catching COVID. So as we treat everything in an industrialized world with another pill for deworming and all the rest of it, it actually affects our microbiome. And we know from other literature that helminths, hookworms, now we don't want the bad ones, but there are human ones, can actually help our immune system considerably. So there's an upside and a downside, ironically, with ivermectin there, to my mind.
All right. The next question then, I heard, why not follow the vaccine program that Help 8 program follows? 0, 1, and then 6 months with antibody checks at 3 months.
0, 1 for 1 month. Okay. I'm going to say something else now too, which I'll bring it on a slide later on. One of the troubles overall with something like COVID, which was relatively new, and Delta variant, which only was named in May, it was here before, but it was named in May, is gathering the evidence and getting it out as soon as possible, which can mean not peer-reviewed, but using what seems to be reasonably good evidence before it may take another year to get peer-reviewed. So we're in that phase of having to rely on what seems reasonably good evidence. We know that 8 to 12 weeks may be the sweet spot for getting the biggest antibody response. But in countries like the UK, they also did it, so more people will be at least half vaccinated in that time frame. But it was shown that their antibody responses was 4 times more when that gap was larger, that 8 to 12 weeks. And it's also been shown that about 10 to 20% of your total antibody levels, 10 to 20% of that will go on to form plasma cells as part of your immunity, which are in the lung. And they are the ones that have the memory. So we get memory cell immunity, which will be in the lung at 10 to 20% of the height of what the antibody level was. And so the Pfizer vaccine can largely work by having more plasma cells in the lung, probably, which works in our lung to stop us getting hospitalization and or dying, very serious infection, but they're not present in the upper respiratory tract. So we can have 1,000-fold higher virus in the upper respiratory tract, which then spreads very, very easily, even though we didn't have it ourselves. So that's one of the things I'd say, well, 1 month, after 1 month, and then 6 months, I was at 0, 1, and 6 months. The other one underneath, and we're all guilty of it in the Western world, if everyone was to get a booster vaccine after 6 or 8 months, then large parts of the world will be denied any vaccination that could get it. So at the moment, for a number of reasons, it's primarily been looked at perhaps those particularly vulnerable people, and that may include the elderly in rest homes, who had been vaccinated 8 months or so ago, should be available for a booster. Perhaps frontline staff should be available for a booster. But we just need to wait and see, do other people in the population start catching infection too much before we give the boosters and deny them being given overseas?
Thank you. Can the vaccine affect fertility in younger women?
There's absolutely no evidence at all for that to have happened. And originally in the first 40,000 randomized controlled trial, they did not sensibly, well, ethically, include any pregnant women or any children, because it would be unethical to do so. Always very, very cautious about pregnancy. But since then, when the vaccine was licensed, and there's several 100 million people being vaccinated now, since then, there's been no adverse outcomes that are any higher at all in vaccinated pregnant women who had been given it, they didn't know they were pregnant, who had been given the vaccine, compared to the normal population that hadn't been given the vaccine. There's quite a reasonably high miscarriage and adverse event rate in pregnancies anyway, but it was no higher in the vaccinated group compared to non. There is some fake news, and one of them was a so-called, bit of a long story, I'll truncate it. He called himself ex-vice president of Pfizer, and he's a doctor. And I looked him up because he said, once you catch it, you can't get pregnant. And I looked him up. He had never been the vice president of Pfizer at all. He had worked for Pfizer 20 years ago in a small laboratory, Pfizer laboratory in England, and had been laid off 20 years ago. And he just speaks, I must say, absolute rubbish. He used to be a good researcher, but he's lost the plot somewhere along the line. And all his colleagues have said so too.
Good, thank you. Is it correct that immunocompromised people, such as those taking immunosuppressant medications, are not really protected at all through the vaccination?
Once again, we've a lot to learn. They may not be protected as much. I'm going to give two responses on this. They may not be protected as much because their immune system is not working so well, so they can't produce so many antibodies. They may be able to talk to their clinician and try and do some timing. So if they're on phases of it rather than all the time, if they're on sessions of immunosuppression, they may be able to time it when they're on the least immunosuppressed to try and get the most from the vaccine. And there's just some, don't put too much credence on this, they're likely to be at greater risk, yes, of catching infection. But if they're immunosuppressed, they're less likely also, as I said, with dexamethasone used as a treatment, they're less likely to get that second phase as well. So they may be more likely to catch the infection, but it may, for some people, I'm not saying most at all, give some protective value by not having that second really allergic large response.
Does the Pfizer vaccine reduce viral load and transmissibility if someone has a breakthrough infection? And if so, by how much?
As I was saying before in a slightly different way, it does not seem to. Whether you're symptomatic or asymptomatic, we still have a huge viral load in the upper respiratory tract, unfortunately. So the breakthrough can give a huge viral load, but we may not get seriously ill because we've got more of these plasma cells in the lung that do their job. But unfortunately, it can be 1,000-fold higher, which is why the Delta virus is so unbelievably infectious. It's completely different to earlier strains.
And do the vaccine risks outweigh the benefits for younger patients?
I've got slides coming up or near the end, so if you don't see them, look at them. And I've specifically got the myocarditis one there. And I've got a whole lot of other slides, not a whole lot, 2 other slides with about 5 points on them each of the significant increased chances of a number of other medical conditions, including kidney disease and such like, that you can get if you catch the COVID infection itself. So I think children, and then there's long COVID, and a lot we have to learn about long COVID yet too. And that can occur in 10 to 30% of people, especially women and tending to be middle-aged, but certainly not only. And I've known under 30-year-olds have long COVID, and a year later, 15 months later, still have long COVID, chronic fatigue-like symptoms, really, really bad. So in general, I think at least at the moment, over 12-year-olds, the data is quite clear. There's low chance of under 12-year-olds and or younger dying, but some do. Unfortunately, some do. And I think it is still definitely, the risk profile is still definitely for having the vaccine.
These questions just keep coming, but there's...
That's right. That's fantastic. No, I'd sooner show you none of my slides and you can put them online later.
Oh, your slides aren't going to be online as much as your recording is going to be online. So
okay. Yep.
People will have to watch our recording.
Yep.
But I'll continue. What about pets? Are they at risk, and can they carry the COVID and shed the virus?
All of that, yes. But so far, it seems to be in really low numbers. It's a future potential risk that if the virus was to mutate more and become an issue in animals, it's a difference. We've had published minks, of course, a whole lot of minks. Was it in Denmark or somewhere caught COVID virus, and they were all slaughtered. There've been the occasional case of animals catching it. There'll be more than we know of, but there don't seem to be any reliable evidence of major outbreaks or anything caused by it. So I think it's a potential future cause rather than a current known cause. Not to say it couldn't mutate to that in future.
And how does the vaccine immunity compare to natural immunity?
That's a good question. One we don't know for sure yet, but once again, I was reading last week that I said earlier that catching an infection, other infectious diseases before COVID came, vaccine did not give immunity for longer than any infectious disease to date. But it seems currently that when people have caught COVID and subsequently had a vaccination, then they get much, much higher antibodies than they ever did when they had it naturally. So it may give, jury's out, time will tell, it may give significantly longer immunity. And it's possible even with this longer gap between doses and or catching the infection, that it may give longer immunity than catching it normally. And so that may give a longer protection. Really good questions. It's fantastic. Thank you.
So Ben, just to reiterate, it's your recording that goes is available to people afterwards, not like handouts. And
Sure,
I'm getting lots of people saying, please, can we see all your slides before the evening?
Okay. So, at worst, can I just ask, at worst,
yeah,
if it stopped, but I just slowly click through the rest of them.
Sure, you can
could
do
at
that.
least have them.
Yeah, you do.
Perhaps, yeah. Anyway, shall we start? Okay, we'll move on. Is that all right?
Yeah, lovely.
Okay. So the basics, I won't spend time. It's similar to SARS, the original SARS, COVID-1, 80%, and to back coronavirus might be 96%, but there's probably an animal in between. Viral load in the respiratory tract at time of symptom onset or first week of illness, then decline. So that's when we have the most viral load in the respiratory tract that first week. And so it's likely most infectious just before we get symptoms, as with influenza, and then for 5 days or so after that. There is also fake news, and it's important to know this, that the person that developed 20 or 30 years ago the PCR test said it could not detect disease. And they're right, but people have misused that information, but I'll come on to that shortly. When you're incubating the virus, and we'll say COVID, when you're incubating it, say for 4 days before you get symptoms, you haven't currently got the disease. You've got the agent that causes the disease, and the PCR test may be positive then, so technically you don't have the disease or the infection yet. Then when you get the infection, hopefully the PCR will be positive, so it's true then you may have 1 billion virus in you. Then after 7 days or so, when you've got over the symptoms, you'll still have dead billion viruses for 10 days, 2 weeks or so, that the test will still detect, but it doesn't mean you've got the disease. So technically they're right, and nor does wastewater have the disease. It's found the agent that causes the disease, and it may, when it's in a person, it may or may not have incubated for long enough to have symptoms yet. I just make that. Maybe in the upper respiratory tract for 17 days, and it can be longer in some people, especially immunocompromised. One swallow does not a summer make, as the expression goes. Just because your RNA is positive, if it was 3 weeks after the disease, for instance, after you got over the symptoms, it's highly unlikely you would be infectious. And it's unusual to be able to culture a positive COVID virus after 9 days. I won't dwell on this for too long. The gold standard is often called the PCR test. False negative rate is the missed detections. So before we develop symptoms, the 4 days before we develop symptoms and before we get the symptom onset, false negatives before symptoms are 100% right at the beginning of the 4 days. And so day 1 of the incubation, and then they drop down to about 67% on the day of incubation. 67% on day 4, the day of incubation, the PCR test may still be negative. Then missed detections on day of symptom onset, you may only find 38% positive. And this is from a meta-analysis study. You may only find 38% positive, which is why we keep testing again and again and again, which is actually the gold standard is not that gold. And increasing again 21% 4 days post symptoms. So false negatives 21%, and then it gets false negative 66% on day 21, as we'd expect. But you may look at that. So overseas, it's a very useful test because if it's positive, it's bound to be there, and only 1 in 1,000 may be a false positive. But a negative test can never, ever rule out COVID infection. It may, for instance, the virus be localized in the lung and not in the upper respiratory tract. So a negative test can never, ever rule out. Here's the red line of the virus increasing. And this is the incubation time, say 5 or 6 days before, up to day 0, which is when we start our symptoms. So we may or may not. NAAT is effectively the same as PCR, polymerase chain reaction as a nucleic acid amplification test, NAAT. So they may be positive then. Here's when the most is, and the symptoms start going, and we may or may not find a PCR positive for later. But there's still lots of false negatives within that time frame. Initially, what happens, the viral antigen is there, the whole virus, which is found in the laminar flow tests. And so they can be done at home or as you go to work, but they only detect 50 to 60% of the positives when you have an infection. So once again, good if they're positive, but you sort of have to disregard them if they're negative. The viral RNA is the PCR test, which may be 80, 85% detection rate. Still doesn't get them all anywhere near it. Then maybe 2 weeks, 10 days or so afterwards, in the blood, we then get the IgM antibodies, but that might only be 50%, 60% of people. And then maybe 80 to 90% of people will get the IgG antibodies. So retrospectively, if somebody had IgG antibodies, we'd know that had been in contact with COVID. They may or may not have got symptoms. And it's something very interesting, very briefly, what I found was interesting. There's a large blood bank study done across New Zealand looking for the number of antibodies in all these healthy people that had donated blood. And the percentage of antibodies, if it was expressed across New Zealand wide from a biostatistical reason, showed there's about 5,000 positives when the total New Zealand at the time was 2,500 actual detected cases, and that's from the community. So we may have twice, as we'd expect, twice as many infections as is known, and that was in the community. Transmission, maximum in the first week. Severely ill and immunocompromised may have prolonged shedding. It's not common, but they may have prolonged shedding. And as I said, very low numbers of PCR positive. Very low numbers may be very early incubation, or it may be a historical case from 2-3 weeks or even longer at times. Those without symptoms can transmit infection while they're asymptomatic. Quite likely, especially with Delta virus. Mild symptoms, of course, we never know if somebody before they get symptoms is pre-symptomatic or they're going to stay asymptomatic. But they carry maybe 1,000 times more virus in the upper respiratory tract. So very, very rapid transmission. Maybe each person with this Delta virus can pass it on to 5 to 6 others. And the Wuhan original virus was more like 1.5 to 2 people. This is 5 to 6. It's massively different on an exponential growth. So vaccination is the key one, but physical distancing, testing, tracing, self-isolation, but at a paradigm shift, different level to what's been done before. And that's why I think people just haven't got on with that and might think, well, Perspex should, if it's high enough, it should stop floating over. Just think of smoking a cigarette. Most transmissions of airborne viruses, especially something as infectious as Delta virus, Delta COVID virus, or measles, is by shared air. Shared air is the key one. Think of smoke, cigarette smoke, shared air. And so the households are where 80% of transmissions occur. One person comes into the household, it's almost impossible for the others not to come down with it. And most of a household, at least 80%, will come down with it. And it's from one person to another and through primarily in the air. And of course, wherever people meet up. Outside of a covered area, smoke dissipates rapidly and dilutes, so it's much less common. Any enclosed environment. Most super spreading events, including concerts and such like, occur indoors. So although the average person with Delta may spread it to 6 others, 8 of them might not spread it to as many as 6, but 2 of them may be super spreaders and spread it to 15 or 20. And we never know who they are. And as I think we all know, I won't dwell on, any inflammatory condition, and that may come in with that second part of the disease where we get this hyper delayed reaction. Any inflammatory condition includes those that I've got there, the older age, hypertension, diabetes, etc., etc. They're all inflammatory conditions and pulmonary diseases. We're more likely to be at higher risk with that delayed hypersensitivity type reaction. And I've shown the slide before, it still holds true. The virus is about 0.1 of a micron, as I said earlier, so it floats very happily like dust in the air. Opening an external window or an external door will help dilute out that air. But even when we're further away, the longer we spend over here, we don't know. Originally, there may have been, perhaps we may have had to, seasonal influenza virus, we have to breathe about 200 before the average person will come down with seasonal influenza. And so the average person with influenza may pass it on to 1.5 others. We know that Delta virus, well, the early Wuhan virus, we may have passed it on to 1 or 2 others. And so the infectious dose won't have been 800, it was more like 200. Now, with then the British strain came along, it was about half that. So it's probably about 100 virus. And now Delta is a whole lot more. And I'm making the figures up. It's not based on science. It's unethical to do the trials. But I'm guessing it may be about 50 virus, the Delta virus only, that we have to breathe. And we're shedding vast numbers of it. So anything can help. We don't know how well the N95 masks work. They'll certainly stop large droplets. Theoretically, they stop the 0.1 microns. I'll get caught up, but we're not absolutely certain. And various experts think 2 different ways on masks. But personally, I think they probably work and reasonably well. Not as well for Delta, but reasonably well. And just re-emphasizing smoke is concentrated in small spaces. So if somebody's been in a hotel room all night and say they have COVID, and I've been in hotel rooms where I have turned off the air conditioning because it's too noisy. So if you've been smoking a cigarette, the equivalent, all night in the hotel room, and the air conditioning is not recirculating, and you open that door in the morning, as has happened, and all that smoke, only you can't smell the COVID virus, would flow out into the corridor. And if somebody on the other side of the corridor opened at the same time, it's easily going to go in your breathe in 50. Just think of smoking analogy. As I was mentioning, the infectious dose is the average number for any particular different microbe, any different species that the average person has to breathe in before they're likely to succumb. Old milk, and that's not a species, it's got many species in it, we can, once it starts clotting, there's over 1 million per mil, and the average person might start getting ill if they drink more than 1 million per mil of old milk bags. Salmonella, we have to ingest more than 1,000 on average, and less than 1,000 will develop immunity, will get a subclinical infection with that strain of Salmonella. Influenza, as I said, about 800, Campylobacter maybe 500. And COVID is perhaps more like, was 200, but maybe approaching 50. Norovirus is 10 to 20. Measles is 3 to 10 infectious dose. We just pay to bear those in mind. Here is the infectious dose limit, the red line. And so that's going to be different heights. They're going to be 50, say, for Delta and 800 for influenza. What happens in our immune system, the microbe starts increasing, the black line, our immunity picks up, hopefully neutralizes it before we get symptoms. That's called a subclinical infection. But when that particular species increases and gets below the infectious dose limit for that microbe, then we get clinical symptoms, and we hope our immunity cuts it out, because if it doesn't, this may keep on going and we die. And so the average, everyone's familiar now, I think, with row values. Influenza may be 2 to 3. Measles is 12 to 18, so largely based on the infectious dose. We can tell these on, but now it's thought maybe we are about 5 to 7 for Delta virus, way up here. The average person, if masks and such like are not used and or isolation, the average person will pass it on to 5 to 7 others, which is exponential growth. I won't spend too long at all on this, but people ask about herd immunity, which we can't get if we're not stopping infection. With measles, we can get herd immunity, but if we're still shedding virus, even after vaccination, and a large number, it might only reduce our shedding of the virus by 50%, a number of cases, then we're never going to reach herd immunity. So if there was a vaccine, we'll say measles, that's almost 100% effective, then we can stop it. Herd immunity, if it's 100% effective, and the row value is like influenza, 1.1, we'd only need to vaccinate 10% of the population for us to have herd immunity. If the vaccine was 95% effective, remembering Pfizer's only 95%, well, now it's dropped a bit, of us getting serious illness or death, not of spreading the virus. If it was 95% effective at also stopping the virus spread, then at a row value of 3, then we'd need about 70% for herd immunity. But when we get up to a row value of 5, we're getting up to 85 to 9% of herd immunity, and row value of 7, we can't do it. But we can't anyway, because half of us will still be shedding the virus. That's just different numbers. So the vaccine, do I need any questions at the moment?
We've got plenty of questions. And I've just had a message that with our new website, if we don't get through the slides, actually, as well as the recording, we're hopeful that we will be able to post your slides as you were suggesting. Okay. So the heat is off, we hope, and I can tell you'd quite like to have a few more questions.
Sure.
Should the border workers get a third dose, as many had 2 doses, but that was 4 to 5 months ago? Thinking of our border workers who need to be.
I think we can only go on the stats. Incidentally, I'm 66 years old, and I had early on decided I would get my vaccine nearer to when the borders opened, thinking there's very little in the community in New Zealand. I wanted my antibodies as high as possible at the end. I couldn't see, other than border workers, I couldn't see why you'd vaccinate vulnerable people early on, because I'd lose their immunity by the end. However, I think we have to go, people that are younger are more likely, as in under 60, are more likely, and this is purely conjecture, to have immunity for longer after vaccination. So I think we'd probably tend to have to wait. And when they first started catching it, probably their symptoms will be less. So if border workers, and we've got several thousand of them, started getting COVID, who had been vaccinated, that would be the time to start vaccinating all border workers. So we'd go on the evidence. And or if we saw that overseas.
Please clarify about our children and their risk of contracting COVID. There seems to be conflicting evidence, especially seeing as a very young child got COVID recently.
I haven't seen enough evidence on it and or read enough on it. They do catch it, definitely. A much, much smaller number of children die from it, but some do and or get serious illness, and they spread it rapidly. They can shed it lots. They can spread it lots. So yes, children are definitely catch it and can get symptoms, but it's unusual for them to die. But if it's your child, of course, statistics don't matter. So I haven't been as clear as I could be, but I hope that helps. Mm-hmm.
And if the evidence is showing that 12 weeks has benefits between first and second dose, leading to reducing the need for booster doses, why aren't the experts changing the process in our rollout?
One, I agree. Two, now in New Zealand, that we have a scenario of potential community major outbreak. I think it's going to be contained, but we never know. Then suddenly you want as many people vaccinated as possible, as soon as possible, as far as the country goes. But the ideal 8 to 12 weeks from the UK, they found, was the optimal for the most antibodies. One shot, though, will give you 50% protection or thereabouts. So
that's why they're not changing the regime at the moment. Yeah.
That's right. I suspect they went. It's very hard on thin evidence for a start to change a whole system. And it's quite hard to change a whole system. If you've got 300,000 people booked at 3 weeks, you can't suddenly say, no. It's very, very hard.
They're using wastewater to test for COVID in the community. However, many people have septic tanks in the Whangarei and Northland districts. So how can this be a true test to base anything on?
It's never a true test. It is an aid. So yes, if most people have got their own septic tanks, it's not going to be helpful at all. We could do without wastewater testing completely. Often it gives perhaps a 4-day, 5-day pre-warning. If there was none, say, in a town, no known cases of COVID in a town, and there's no, or a city, and there's no isolation hotel, and you start getting positives from the wastewater, you'd start thinking, something's looking suspicious. We might have some cases we don't know about.
Thank you. What about the vaccination reducing the chances of long COVID?
Vaccination itself will never cause long COVID, ever. Vaccination will reduce your chances significantly of catching COVID, perhaps 50 or 60% of catching COVID. And but if you do catch COVID, dare I say it, symptomatically or asymptomatically, 10 to 30% of people, especially women and 30 to 50-year-olds, but definitely not only, can get long COVID, which is a bit like chronic fatigue syndrome, although it's ill-defined. Some people tend to get it for a month, and some people get it for over a year. There's a quirk there, which I might as well say now. The quirk is, I was listening to some work from Yale University, and I hope I've got my figures right somewhere here, from Yale University. If you get long COVID because you've had infection, of course, one thing that can be tried is then getting a COVID vaccination, and 40% of the long COVID people show improvement, but 15% get a lot worse with their long COVID symptoms, which is a rather awful, actually, an awful choice to make, because long COVID, chronic fatigue is really, really bad.
What's the value of the saliva test, Ben?
This is an interesting and somewhat complex reply. The saliva test, when the proper method is done, and there's 2 laboratories that I know of in New Zealand that can do it, it is just as accurate as the PCR swab test. And personally, I think it's politics and money that's stopped it being introduced. It's actually cheaper to do. And there's other benefits too. Infection control is largely about human behavior. And if you've been going to work, say a front line, and you've had 3 weeks in a row where you've felt a bit snivelly in the nose, after you've had 3 PCR swabs, you're not going to volunteer that you feel sniffly in the nose and get yet another per nasal swab, but you're going to have no trouble at all donating a saliva swab. So there's other saliva sample. So the saliva test is definitely as sensitive as the PCR swab test and should be done without doubt. And there's some reasons I just cannot comprehend. It's been known that good in the USA and such like for over a year now, and there's a couple of labs in New Zealand that can do it very well.
Wow. And somebody's just checking that they heard correctly. Did you say at the beginning to keep in mind that within 3 to 4 years, the whole world would have had COVID?
Yes, and I did that knowing I'm in New Zealand, and I'm just going to run another scenario past you. Delta virus is a game changer. And once we can already see, Australia and New Zealand, that it's almost impossible to contain it even in isolation hotels. And so we've vastly reduced the numbers of overseas people coming in, as much as anything, to reduce the risk of bringing COVID, that Delta virus that we can't pin down because it is so infectious. So it's my own belief, I know it's contrary to some of the things that have been written, it's my own belief that at some stage at the beginning of next year, we'll say the first 6 months, somewhere in January to June next year, as we start opening up the borders, even if we do a PCR test for everybody and a laminar flow test for everybody, we're not going to be able to isolate everybody ongoing. Then about half of them are going to be asymptomatic carriers that have COVID and not detected, and it will go like wildfire when we get into New Zealand. We know that Iceland has about, I think it's almost 270,000 people, and something like 60 or 70% of them are vaccinated, and they're reasonably good with masks. And they currently they are 1/14 the population size of New Zealand, fairly sparse population. And they currently have 86 cases per day in Iceland, even though they've got a high vaccination rates and mass. So if we multiply that 86 by 14 per day, that could be what we expect in New Zealand next year at some stage. And so it's unfathomable, given that if each person with it on average passes it to 6 to 7 others, that everybody in the world would not have been caught COVID unless the vaccine had stopped them getting it.
Oh, right. Somebody's saying then she's 63 and had sudden and unexpected postmenopausal bleeding 4 times over the time of her first and second vaccines. A gynecologist told her that it wasn't caused by the vaccine, but she's also heard that links have been ruled out, and she's a bit skeptical as she's seen other stories similar to hers online.
Sure. It's always very, very difficult to definitively say that, for instance, that is not caused by the vaccine. The nearest we can do, either that it is caused by the vaccine or that it is not. And as humans, we are emotional beings, and cause and effect is high in our mind. So we know if I get a jab with something today and I come down with flu-like symptoms tomorrow, I in my mind will believe it was definitely that jab in the arm that did it, no matter what they tell me that the vaccine can't give you flu, for instance. However, in the randomized controlled trial, they're the same number of people come down with flu symptoms as do not come down. So the general population, we can only look at it from 100,000 women who are newly menopausal, who had not had the vaccine. How do these bleeds compare to 100,000 women that had the vaccine? Mm-hmm. And if the numbers are the same, then you still can't say in this particular one-off instance that it wasn't the vaccine, but all you could say from 100,000 people, there was no data to support it.
Thank you. Somebody has a very small consult room. At present, can only see asymptomatic patients in my room. I worry about opening a window, as in I'm just creating a positive flow through the rest of my practice as soon as my internal door is opened. And he's got a question mark asking for advice, I imagine.
There's no simple answer. One, make sure you're vaccinated. That will reduce your risk by half. Opening an external window, like a cigarette smoker, will reduce your chances. And that's the only advice I can give. And if it's a small room, that smoke concentration is going to be more concentrated. There's no simple answer. Reduce your chances. Hopefully they're vaccinated and they'll reduce their chances by half. Otherwise, frontline, we're in line for more likely to be catching COVID. As with a number of other things, as with measles if you weren't vaccinated.
Will we be able to make a vaccine to combat the Delta variant?
It's very hard to look into the future. I'm certain Delta or the next one that may come along, at least with the messenger RNA vaccines, they can be repurposed very fast. So they will be working on, can we improve this vaccine at all by changing the nucleotide sequence? COVID virus has about 30,000 what's called nucleotides, like it's guanine, cytosine nucleotide, and there's about 3,000 of those 30,000 makes up the spike protein. And so maybe somebody can find a way of protecting better, but we don't know until either Pfizer BioNTech release a new trial that they're doing, that's what it would take for them to try repurposing the existing vaccine a little bit, which can be done fairly fast, just in a few weeks. Mm-hmm. Fairly fast. This is just a normal cell. Every one of us has a normal cell. Here's a nucleus in the middle, which every cell has, and there's DNA in the middle. And we have various what's called organelles, including ribosomes, and that becomes important because they make our proteins using a bit of RNA. So normally the RNA comes as our DNA is like a recipe book for making all of our proteins. We have different proteins for the heart, lung, liver, etc. And so when we need more lung protein, the recipe book goes to the chapter on lungs, makes a copy of it in the form of RNA, and the RNA migrates out of the nucleus. Once it's out, it cannot get back in. That's really important for vaccine hesitants who are worried about RNA getting in to change our DNA. It cannot get back in once it gets out. There's a specific enzyme it needs to get back in, and we don't have it. That bit of RNA, messenger RNA, comes around to our ribosomes that effectively photocopy it and make the protein. But I'll come back on that. So here's the DNA. There's a copy of that chapter. The messenger RNA comes a one-way trip, comes out of the nucleus, comes around to our ribosome, and it comes along the ribosome. The ribosome reads it and photocopies it, in effect, makes amino acids, and then which join together to form polypeptides and then form proteins. in a nutshell, I'll say here, but I'll do it later too. The messenger RNA vaccine doesn't come out of the nucleus, of course. It comes in from the outside and comes into here. It's never seen a virus itself. It's a copy of the spike protein only made in a laboratory. And this ribosome makes tens of thousands of copies of that spike protein. So our own body is commandeered to make the spike protein. This whole cell then dies, the spike protein's released, and our immune system thinks that's foreign, and it is, and attacks that spike protein, and that's what gives us our immunity. So we make it, rather than injecting parts of virus or parts of bacteria into us, our own body makes that spike protein. Spike protein is a bit like a door handle. It's attached to the virus, and we might have different, here's a virus, say, and I should say the screw is a bit like the spike protein that holds the door handle to the door, and there can be slight variations of it, which is the equivalent of variants of a COVID. And there's a few threads on that, and the messenger RNA is when we take copies of that thread, and if we get the ones that are in common to each of these, then the messenger RNA will have each of those threads, which we then multiply. I haven't said that very well. As opposed to the Oxford AstraZeneca, that uses a chimpanzee adenovirus, which is non-pathogenic to humans, but you can see why some people get nervous. Chimpanzee adenovirus. It also sequences in a laboratory, so it's never seen the actual spike protein itself. It's sent on the internet, and it's copied in a laboratory. We can synthesize these things, and that spike protein is put into the chimpanzee adenovirus, which comes into us, and there's immunity. So you can see why people are a bit nervous about the AstraZeneca from a virus being jabbed into you. So just coming back, this RNA is created, the messenger RNA, it's a tiny part of the virus, is made on a keyboard in a laboratory. That then gets a fatty coat put around it, and in the laboratory, that fatty coat then attaches to cells, and the RNA comes in, and our cell makes lots and lots of spike proteins, which our immune system then picks up on. That's it in a nutshell. Spike protein. So we only take one tiny part, which is made in a laboratory. It's not from the virus itself, and that becomes the messenger RNA. Here's that tiny bit of a synthesis, homemade synthesis of spike protein. Here's the oil drop around it, or lipid drop, that gets injected in. The lipid attaches to the cell rather than the spikes attaching to the cell. The lipid attaches to the cell. The messenger RNA comes in, goes into that ribosome, produces hundreds of thousands, and it cannot get near the nucleus or near our DNA. The cell bursts, and immune system suddenly realizes that's foreign, and that's where we get the antibodies from. Okay, there are adverse reactions, and quite a few of them. The second shot tends to be more, and this is higher than influenza. So we have to be realistic, but it is our immune system. Fatigue, headache will happen in a small number of people for 1 to 3 days. That's our immune system being fooled into thinking, here's a foreign infection, and winding up, and our whole immune system starts fighting it, and that's why we can get fatigue, headache, muscle, and a small number of people will get fever and such like as well. A very small number will get anaphylactic reaction, but maybe 1 per 100,000, but that's why you stay behind afterwards. The messenger, I won't spend time on this. They're much easier to make than messenger RNAs than, for instance, influenza vaccines. We don't need eggs or anything else. They can be made in a laboratory. Very, very simple vaccine, and they can be redesigned to a new variant if required. In future, I'll just mention this, that same tumor or a cancer is effectively a foreign protein, and that something's gone wrong when we're making our protein. And so we may be able to use that same technology to what is an aberrant protein, create some messenger RNA, re-inject it in, and have our immune system attacking the cancer. That's it in a nutshell. Pretty amazing. The messenger RNA technology was first being looked at in the late 1980s and early 1990s. So it's also work had been done on rabies, influenza, HIV, TB, Zika, etc. before there's enough money and or need for the COVID vaccine. So it's not entirely new as such, but it is to the population. There's only 4 key ingredients in the messenger RNA vaccine. The active ingredient, the messenger RNA, some lipids and oily type substances, including polyethylene glycol, which is antifreeze. That may be what some people are allergic to, but they can't just suddenly go and take it out now, because you have to go through all the patterns again. But a very, very small number of people get that may be the anaphylactic part there. Then there are a few salts added in just to keep the pH right, the acidity right, and a bit of sugar is used as a cryoprotectant. We do not need any preservatives in it because it's frozen at minus 70 degrees. So there's no thimerosal, no antibiotics, there's no adjuvants like aluminium, there's no virus or part of any virus that's ever been alive or dead. It's synthesized. A tiny fraction of the 30,000 units is synthesized in a laboratory only. There's no protein, there's no egg products. So some of the vaccine hesitant have issues with some of those. New variants. So there's evolving viral variants, as we know, with Delta now. How long will immunity last? How well does it work to the new variants? And we tend to think how rapidly does it spread? How many people can you pass it on to? And is there any change in clinical condition? And there's a difference between preventing infection and communicability. This Pfizer vaccine will only reduce the communicability by about half, unfortunately. But in our upper respiratory tract, when we do catch it, we may have much higher numbers we do have much higher numbers of virus. So it reduces infection by about half, perhaps 40 to 60%, but it does very, very, very much reduce serious infection, hospitalization, and mortality. We've got 24 more variants we could have before we go back to Alpha 1, but we're up to Delta at the moment, just doing that along the line. And there's a difference between variants of interest. Some people say, oh, what about Epsilon? That I think is not even a variant of interest yet. That's when there's always different mutations going on around the world. A variant of interest or a variant of concern. A variant of concern is when it's got bad enough, like Delta, that we think, no, we need to take note of this. Just spend some time on this. We know about the R values as transmissibility. The Wuhan strain, on average, probably passed on to each person that caught it would pass it on to 2 other people. So after 3 series of transmissions, 2 people, and each of those 2 passed it on to 2 others, and each of those 2 passed it on to 2 others. 2 2s are 4, 2 4s are 8. So after 3 different series of transmissions, or 3 incubation times, if you like, you may get 8 cases if people weren't isolating and wearing masks and all the rest. When we go to R3, which may have been the next strain, the British and Brazilian strain type of thing, 1 person getting it would pass it on to 3 other people. And so we would have 3 next transmission series times 3. 3 times 3 is 9, 3 9s are 27. So 27 cases rather than 8. But now we're looking at 6 or 7 transmissions in the Delta virus. So the first person infects 6 other people, and that 6 each of that 6 infects 6 more, which is 36, and each of those 36 infects 6 more. So in a very short time, we have, rather than 8 cases with an R2, we have 216 cases with an R3. And that's why it's this unbelievably infectious type virus, really, really huge.
How long does the viral load take to shed with the Delta variant?
How long? We can end up with about 10 to the 9. Virus within us, so that's 1,000 million, which is a billion.
Now, how long does it take for the viral load to shed?
Well, we start shedding it at maximum, say a day or two before we get the symptoms. And then that's the maximum when we get the symptoms for about 7 to 9 days, but it can keep going. Like as we shed 1 million, it's like wastewater. We can keep losing them, but they may take 2-3 weeks to get rid of most of them.
Right.
So the PCR swab would still be maybe positive over that time. Interesting, isn't it? What's happened? I just make the comment that that if there's 85% efficacy, because it's dropping down a bit from the 95% that it was, if all 5 million in New Zealand were vaccinated, then there'd be 15% that had no protection, which is 750,000. But if there's vaccine hesitancy, so 20%, that's 1 million. So that's why it's hard to imagine we couldn't end up with really large numbers in due course going through New Zealand when a lot of them are asymptomatic. Once it gets going, it'll go like wildfire. It's not very politically correct to say so, but it's hard to imagine. And in Britain, I've got some graphs coming up. They are something like 75% are vaccinated. 92% have antibodies, even though 75% were vaccinated. And that's because there's so much COVID going through the population of Britain. So more have got antibodies, about 92%. And now they're having a real peak in numbers again of COVID infections. But, and this is the important part, their hospitalizations and deaths are way down. Because the vaccinations and the antibodies have hugely reduced the hospitalizations and deaths, but not the infections, which are going up. Does that make sense? But it seems a bit strange. Anyway, fake news. I'll just go through these reasonably fast. There's about, I think, 12 or 15 people are responsible for 50 million followers of fake news. It's a real trouble. Last year, Facebook promised that no company should make money out of fake news. They then immediately turned around and made programs to help spread fake news, and they make $1 to $2 billion US from fake news and the advertising associated with it. Anti-vaxxers tend to say COVID is not dangerous, vaccine is dangerous, and vaccine advocates cannot be trusted. They're the three main things that tend to keep coming out with the anti-vaxxers. But even if it used to be, it's certainly gone down now with the outbreak in New Zealand, even if 30% of the population were vaccine hesitant, only 1 to 2% of them are what I would call flat earthers or complete and total anti-vaxxers, no matter what. Vaccine hesitancy tends to be people, which is really good, they just want to know more information. And that's good. We must listen to see what's the information they want. And I've got a slide on that later. These are some of the things that come up. In a recent candid interview, I got all these on the net. I don't have Facebook or anything, and I went to give a talk, and I got all these things over it. A recent candid interview, Bill Gates outlined that despite the comparatively small threat of coronavirus, he and his colleagues don't want a lot of recovered people who've acquired natural immunity. Just all absolute rubbish, of course. The truth about diseases and viruses, they were both created by the pharmaceutical industry, who uses the flawed germ theory to sell medicines and vaccines to the populace. for monetary gain and population control. Just all complete rubbish. It changes your DNA. You won't be human. You won't be the creator. You'll be a genetically modified organism. You can technically be patented. It's likely you will not be around to worry about the messenger RNA vaccine. And these, from an academic study, where in Facebook, 569 utterly false news, no doubt about it, fake news pages were reported. And from them all, there's 912, only 2.3% were removed. They're not the slightest bit interested in cutting their revenue. And you get all this chip business. Is there a microchip there? Is there iron in there? You can put a magnet on your arm and all this sort of rubbish. And it ties up with 5G and artificial intelligence. So somewhere Bitcoin comes into it too. But those people that are anti-vax, at least 40% of them only use Facebook for their news source. So we have to be very, very careful and to listen and not back them into a corner, because if you challenge anybody's well-held beliefs, they're not going to change them straight away. In fact, it's going to solidify them. So I say, if people feel respected and trusted, so somebody, well, I'm not too sure about the vaccine, try and find out, tell me specifically, I'd be keen to hear, what are the issues you have about it? Might be, well, I read something that the inventor of PCR said it never diagnoses disease, so clearly it doesn't. And as I said, it's not as simple as that. It diagnoses the agent that can cause disease, but there's an incubation time, and there's a time we still have the dead ones on us. There's one, dare I say it, by Samantha Bailey, and she's a medic from New Zealand who was a GP for, I think, about 2 years. And then she went out onto the, part of what she talks makes sense, but some of it's absolute rubbish. She said there's no CDC, Center for Disease Control in the USA, have no cultures of live virus at all. And she gives a reference to it from CDC to prove it. So you can look up and check, and they don't, which is extraordinary that they don't have any actual virus, even though there's millions. But you look more carefully, and the reference she puts in, and she was a researcher for 2 years, the reference she puts in was from the end of 2019. And when there was none other than in China. And you think, oh, that's really naughty, to really reckless, actually, because now CDC, of course, have bucket loads of it in cultures. So we just have to be careful about really following back on references and understanding them better. It's hard to change someone's mind or beliefs, but we can help them make up their own minds if we listen to what the concerns are and we give them appropriate information. In general, social media is designed to reinforce your own beliefs, not challenge them. And it lacks objectivity. It's not a scientific area at all. And they're continually creating things, smiley faces and everything, to keep you locked into them. And although this is different, Netflix, for instance, says their biggest competitor is sleep. Once people stop watching them, they go to bed. So the biggest competitor is actually sleep. With buying a book on the internet, if you buy a book from Amazon or Book Depository or somewhere else, it's likely to come up with people that bought this book also liked this book and this book and this book. And all the same with music. People with Spotify, people that like this tune that you've just listened to also liked this, this, and this. And you listen to them, and they're right. They're fabulously good. It channels you down that line of more of what you like. But if what you looked up on Google was Dr. Andrew Wakefield, who, inverted commas, proved the association between autism and vaccinations, then once you click on that, show yes, then the algorithm will send you more similar posts to back up that. And of course, there's thousands of everything on the internet. Dr. Andrew Wakefield in Britain was struck off the medical register for completely falsifying all the results. So become famous. And I was talking to somebody in Hong Kong as it happened for about 2 hours mid last week, who said, but there's unfailing. And with a colleague of mine in Auckland, I was down in Christchurch, and she knew him well, and he's a complete and total anti-vaxxer, and said, listen, he had used a magnet after his vaccine, and the magnet stuck, which proves his iron failings in the vaccine. And so that's why I've got this one with the teaspoons on. That's the proof. And she said, so if I got a magnet and went up because she'd been vaccinated with stick, and he said yes, and she said, well, I've got a medical grade magnet and I can stick it on. And she said, what would happen if it didn't stick? And he said, well, it still wouldn't rule it out. And he was saying there's no such thing as COVID. He's a director of a company too. He's Kiwi originally, I think. And there's no such thing as COVID. It's just a cold. But then he was selling cannabinoids, and he had caught COVID and it treated it. And she said, but I didn't think there was COVID. They're mad. So magnetism, that's why I've put it in. There's all sorts that people believe. I'm just going to touch on some of these. Is the vaccine safe? Clearly, the original phase 3 trials showed it was. Since then, there's hundreds of millions of people who have had vaccine, and there's a risk with everything. For instance, myocarditis, 1 in a million. But the risks of not having it are much, much, much greater than having it. The risk of catching COVID is many, many times greater. Does it work? There's absolutely incontrovertible proof that it does. Is the vaccine more dangerous than infection? Absolutely not. Cost benefit, all the different major evaluations from different countries, independent around the world, universities, researchers have showed it is. Can you guarantee no long-term effects? No. You can never guarantee a negative. You can never guarantee somebody's not going to be hit by a meteorite on the road home. But any previous vaccine, there's never been long-term effects which have not shown up longer than within the first 3 months. They've always shown up within the first 3 months if there's going to be a significant effect, adverse effect. But all the immunologists and biologists in the world whose specific field it is say that, when I say all, I say 99%, because that's the same as global warming and such, 99%, there'll always be 1% that are different, but 99% say there cannot be. There's no logical reason why there could be. How can new technology be introduced so fast without risk? Which is a good question, because people tend not to know. It was starting to be looked at in the 1980s, published quite a lot in the 1990s by Hungarian scientists, and then starting to be picked up for Ebola and SARS and rabies. But there was never enough people and enough money with those conditions to further it. So it's actually been 20, 30 years in the making and evolving more. On Fit and Healthy, we covered that. It will not protect you, unfortunately. Is COVID infection that bad? Yes. High mortality rate and long COVID, it is awful. Is vaccine safe for pregnant women? Absolutely. There's been nothing higher than what's normally found in the general population. Why not focus on other ways of combating it? They just don't work well enough. A mask and isolation, you'd have to be a hermit for the rest of your life. What information should I trust? Because I don't trust government, MOH, or Big Pharma. I think explain to people that have a trouble with that, which is quite reasonable. Big Pharma, of course, in the States were responsible for the opioid crisis, for instance, is to say they distill the information from independent universities and researchers around the world. You can look up that information yourself. But when you do a search on Google, put edu for a start, or put evidence for a start, the first word, and then any site that has edu for university is likely to be more credible, but always look back on that. The fatality rate is not that high. Actually true. The actual rate may be 0.5 to 1% or something like that. So it's higher than influenza, but look at the chaos it's caused and 4 million dead already. But they're right. The fatality rate is not huge. Nowhere near as high as SARS, which was 10%. Middle East respiratory syndrome was something like 38%. Bird flu, H5N1, was something like 58% mortality rate. And we dodged a bullet by only, if I can use that expression, getting COVID. Microchips and iron and the vaccine for tracking 5G, you just have to tread carefully with that because you hardly know where to start when responding to something like that. But get a magnet and prove to them that it doesn't, and a microchip wouldn't fit down the needle, and you're carrying a cell phone which can be traced more easily than any vaccine can. I've covered the inventor of PCR. It doesn't diagnose disease, but it does detect the agent that causes that disease. And I've covered even CDC do not have the cultures. Now, vaccine myocarditis, about 1 in a million, as I've said. Myocarditis is usually mild and short-lived, but unfortunately not always, as we know from the New Zealander recently that died. And there are normally about 100 hospitalizations from myocarditis in New Zealand after influenza or viral illness, for instance. Vaccinated people have a 3 times increase of myocarditis than the general population. But catching COVID infection gives you 18-fold more chance of developing myocarditis than the rest of the population. Then these following, which I'll spend almost no time on, are all serious health risks, not vaccine related, unlike myocarditis, so not at all vaccine related, that COVID infection itself increases. Cardiac arrhythmias, 3.8-fold increase. Kidney damage, almost 15-fold increase. Pericarditis, 5.4-fold increase. Pulmonary embolism, 12.1-fold increase. DVT, 3.8. Myocardial infarction, heart attack, 4.5. And stroke doubles the chance. Long COVID is poorly defined. You may get a fever, which you don't with chronic fatigue, you may get fever, brain fog, and lots of other ill-defined symptoms like chronic fatigue syndrome. They're roughly divided into 2 groups, had it for over a month or had it for over a year. And as I said, women 30 to 50s, 10 to 30% of adults post-COVID infection can get long COVID. Causes are unknown, what specific causes are. It's postulated that there's a bigger number of the virus, COVID virus, in the gastrointestinal tract. A bigger proportion of people carry it in the GI tract than the normal population that have had COVID. So maybe it's an ongoing semi-latent infection that triggers the immune system, or an autoimmune. There's a higher percentage of people with long COVID that have autoimmune antibodies, but it's not known. COVID vaccination, of course, well, I shouldn't say of course, does decrease the chances of getting infection by 40 to 60%, and so reduces the long COVID risk by 40 to 60%. It is just interesting that although there's no treatment as such, if people subsequently, so you must have caught COVID before you can go on to get long COVID, if they later get a vaccine against COVID, 40% lose their long COVID. They may have been going to anyway, but 40% lose it, and 15% get it much, much worse. So some tricky decisions for some people to make. Just bang our heads against a wall sometimes. I won't spend time on that unless you're going back on it. Around 30% of the total antibody level goes on to form these plasma cells in the lung to give a memory. And so the higher the antibody level, if it's 10 to 20% go on to give memory cells, the higher the antibody level, the better. This one, COVID cases, this is just very recently, COVID cases in England are 26 times higher than a year ago. 26 times higher than a year ago. So there's August last year with very low cases, and here's August this year, much, much higher. So 1 in almost 2,000 people were infected in 2020, August 2020, or 1 week in August 2020, and 1 in 70 I've got those the wrong way around. 1 in 70 and 2021. I've got those the wrong way around. Then we go on. But this is the mortality rate. There's high numbers, high numbers, high numbers, but this is the mortality, really low mortality. And we put those together and we'll see these were the cases, not so high way back in April before, but look at the mortality rate. We're handling it a lot better now in ICU, so not very high cases there, but in the same month, high mortality in the UK. Then we come through to here, January here, high numbers and high mortality. Then the vaccination came in. We've still got high numbers, but look at the mortality, almost nothing.
Ben,
yes.
I just had a message from the office that we've gone so far over time. We're going to suggest that we wind it up, but that people forward any further questions that we haven't been able to address to you, and we'll post them on the website along with the recording.
No trouble at all. And that's effectively the end of the talk anyway. Way over time, and that's effectively.
Thank you so much. It's obviously of huge interest to everyone, and I do apologise for those questions that remain pending. But as I say, I don't know if you want to give your email address. Oh, there you are. Here's the
there's my email address. So either through you or to me directly, no trouble with that at all. I can't believe there's 304 people still
I know.
Thank you for your attendance and your questions. I got quite a few of them answered, but I'll try my best to answer the rest and send them on to you to post online as well. Mm-hmm. And I hope it's been worthwhile and you've learned something. Thank you for your attendance and your company.
Thank you very much, Ben. As I say, it's been a hugely interesting presentation. Thank you, everybody else, for hanging in there. And do remember to go to our website and you can see it all again, plus hopefully the slides, plus hopefully a bit of a response to outstanding questions. Just use that email. So, homaru, everyone. Stay safe, and look forward to seeing you again on one of our evening webinars soon. Thanks, Ben.
Very welcome. Thank you. And thank you, Mobile Health, for hosting it. Thank you kindly.
Bye for now.
Bye for now. Bye.